I see no snow so far. I actually love winter. I love the snow, but no, I see some snow and love it. If you guys are just joining, we're just dropping our organization in the chat, and then if you're a snow person or not a snow person. We'll give everybody till about 12:05, and then we'll get started. Snow only if it doesn't stick. You just like how pretty it looks, right? I'm here for that too. Wow, 6 inches. Oh my goodness. I know I'm originally from Winchester, Virginia. I think they got about 3 or 4 inches, but I hadn't heard the 6 yet. All right, we'll get started in about 1 more minute. I think we have just a few others joining us. If you're just joining, we're just dropping our organization in the chat, and if you're a snow or not snow person. All right, it's about that time. So again, welcome. We are so excited to have everybody here. It's our first webinar of 2024. Look forward to doing these every third Tuesday of the month this year. So if you tell all of your friends to register and join us, we have a really great lineup this year. First one of the year, so we have quite a few announcements, and then I'll introduce our amazing guests and we'll get started. So let's see. It won't let me minimize my screen. There we go. Quite a few things. We've got save the date for our March Day of Learning is coming up March 17th through 18th. It's at the Westin in Richmond, Virginia. We have a brand new event registration platform coming, so we're very excited for you guys to experience that. So keep an eye out for when registration is launched, hopefully early February, and then we'll also have an agenda to share. If you haven't seen the 2023 annual report, definitely check that out. We'll drop the link in the chat for you to take a look at there. It's also hosted on our website. And then don't forget, this is one of 2 webinar series we're doing. Starting this Thursday, we have our 2SL LGBTQIA+ competency series. It's a 5-part series every third Thursdays, and it starts this Thursday, January 18th. We also have an amazing QI initiatives happening. So if you're not involved with us on a QI initiative project, definitely reach out to Brittany Watson. She can drop her email in the chat. And then we are standing up our governance. So we have a governance interest form. There's a few different opportunities there. We'll drop our governance interest form in the chat as well. And then it's General Assembly session. And VNPC is mentioned in several bills that we're tracking. So we'll have more information to share on that soon. And then something else coming soon that's very exciting is our hospital recognition program we're launching this year. So stay tuned for information on that. And then this webinar recording, as all of ours are, will be available on our YouTube channel within 48 hours. So without any further ado, I'll introduce our title for today is Perinatal Mental Health Fundamentals for the Practicing Clinician. We have 3 guests with us. Dr. Reichenbacker, she's a board-certified psychiatric mental health nurse practitioner, over a decade of experience in psychiatry. She's a committed clinician and educator with experience spanning numerous settings and populations, including both inpatient and outpatient psychiatry, providing care for children and adults with all types and severities of psychiatric illnesses. And I'm going to paste her full bio in the chat for you all to read as well. We also have with us Elizabeth Markey. She's a board-certified psychiatric mental health nurse practitioner and a certified nurse midwife with over a decade of experience in the women's reproductive health care. And I'll paste her full bio in the chat as well. And then we also have with us Beverley Albertson, is a dedicated administrative professional serving as the practice manager for Brookside Psychiatric Specialists, PLLC. With a profound commitment to serving the mental health community, Beverley has been instrumental in utilizing her background and talents to create a positive impact for each patient she encounters. So with that, I am going to go ahead and turn it over to Dr. Reichenbacker.
Thank you so much, Lauren. And thank you, Tiffany, and everyone who invited us today. We're really excited. And truly, like, genuinely very excited. This is a topic near and dear to my heart. I've been in reproductive psychiatry for the better part of the last decade, and feel really passionately about this. So it's just really exciting when I get to talk to new folks and hopefully move the needle forward just a little bit on getting people better mental health care in the perinatal period. So that's what we'll talk about today. All right, let's see here. So basically what I am hoping you all walk away with, this is a short presentation. We will definitely not have time to get into any weeds on the topic of reproductive psychiatry or perinatal mental health, which are both huge topics. I have and can talk for many, many hours on this topic, could teach a whole course on it. So today is really just the fundamentals. I want you all to walk away with enough information that you can start to think about if and where and how any changes can be made in the systems that you all function within to, again, move the needle forward on improving mental health care for perinatal patients. That's going to involve understanding kind of what we as reproductive psychiatry specialists do, what that kind of field looks like. I know there's some questions a little bit around like, what even is that? Totally makes sense. It's very like unheard of. Understanding how hormones actually do affect mental illness during this time frame. Understanding what mental illness looks like in this time frame and how that impacts both maternal and child health outcomes. And then also, and importantly, I think this is kind of an opportunity for us to talk about maybe more specifically what I think are relatively simple, though obviously complicated by all the system stuff that we have to go through, things that we can do to start making changes in how we connect people with care and how we are able to identify people who need help. So we'll talk about screening and treatment referral options and things like that kind of briefly at the end as well. Now, with that said, I'm actually going to turn it over to Elizabeth. She is an awesome perspective. She's worked as a nurse midwife and now works with us as a psychiatric mental health nurse practitioner. So she really comes at this from two worlds and has seen kind of all of the sides of what perinatal mental health means for moms, especially who are experiencing this. So she's going to start us off and talk a little bit about what reproductive psychiatry is, and then I'll jump back in after that.
Great. Thanks, Olivia. Hi, everybody. So we'll start first things first. What is reproductive psychiatry? This field is dedicated to the diagnosis and medical management of mental illness that occurs around the menstrual cycle, across pregnancy and postpartum, and during perimenopause. And as such, it focuses on the unique needs of women with psychiatric symptoms related to transitions and changes within the reproductive cycle. Specialists in this field are educated, trained, and experienced in understanding variations in the presentation, the course, the severity, and the prognosis of mental illnesses that are hormonally mediated, in addressing women's unique psychosocial needs, and in understanding and applying evidence-based and specialty-specific best practices in treating hormonally mediated mental illness. Next slide, please. Why is reproductive psychiatry as a specialty important in perinatal populations? Well, untreated or undertreated perinatal mental illness is a problem with extremely high individual and societal costs, affecting 1 in 5 to 7 women and 1 in 10 men. Up to 85% of these will receive no treatment, and 50% of those who are treated suboptimally and remain symptomatic. Non-specialist care is more likely to result in undertreatment and poorer outcomes due to low provider comfort, knowledge, and competency. Inappropriate treatment practices are common, and they include things like refusing to medicate pregnant patients or lactating patients, even when the risks of unmedicated illness is high, using doses that are too low or outdated FDA pregnancy categories to drive their decision-making, discontinuing medications that were effective prior to delivery, or changing effective medications to those thought to be safer without an appropriate indication of benefit to the patient, and a lack of prophylactic treatment and forward planning due to reduced understanding of the unique risk factors, presentation, and courses of illness within this population. Next slide, please. Trends and barriers that we observe within this specialty include good news that there is increasing awareness and discussion of perinatal mental illness, particularly postpartum depression. There is an increased desire of patients to both prevent and treat perinatal mental illness, again, especially postpartum. And there has been an increase in screening. However, there does remain substantial ongoing gap between screening and treatment, which will be discussed more ahead. Despite these trends, barriers include the continued impact of misinformation, fear, and stigma on seeking treatment and taking medication. For patients desiring care, there remain many system barriers to mental health care access, and there exist very few prevention efforts and programs. And then on the provider side, there is little education on reproductive psychiatry within medical and nursing school programs, and there is no single reproductive psychiatry curriculum or standard of specialty certification. Many patients will seek help from their OB or midwife with limitations to specialized care and limited follow-up. OB providers only have so minutes in a follow-up appointment, and then available psychiatric referrals can often be booked out for months. All right, next slide. Thanks, Olivia.
Yeah, thank you, Elizabeth. That was great. Yeah, honestly, there's a lot of really positive news in this field. The overarching theme is that we can still do more. And so hopefully the more people that learn about it, I think education and information is a huge part of this. The more people can make impacts and the more impacts we'll see. So that's the goal of today. So we're going to talk about perinatal mental illness specifically today. That's the perinatal period is one of the periods that reproductive psychiatry specialists specialize in. And it happens to be that myself, Elizabeth, and our team as a whole pretty much really focus on the perinatal period. That's like the bulk of the work that we do. So this is a great option or opportunity for us to talk about it. For our purposes, I know we have people from lots of different backgrounds here. It's super exciting actually to see everyone from all over the state in Virginia and all different kinds of perspectives that we have. In psychiatry, when we talk about perinatal mental illness, the word perinatal specifically, we define as the entire pregnancy through the first year postpartum. So basically day one of pregnancy up and through the first year postpartum. That varies a little bit. You might hear perinatal used with different timelines for other specialties. So that's important to know. The other thing is I and many of my colleagues like to talk about perinatal mental illness in that broad sense to like capture the idea that basically any mental illness that occurs for in any other time frame basically can occur during the perinatal period as well, right? However, what you will see is that in the literature, what is best studied, what is most discussed, talked about in advocacy and all kinds of avenues, and again, what is best researched is the spectrum of illnesses called perinatal mood and anxiety disorders. So the term that you'll often see and that you'll see in my presentation as well is PMADS. That misses a few key things. Like we don't talk about substance use disorders technically in that category, although almost anybody who talks about PMADS will also include substance use disorders as well. Research that looks at PMADS usually includes substance use disorders. Sometimes they're broken out. The rest of these disorders that I have listed down here are all included under that PMADS header, that PMADS category. And that is really the bulk of what we know about and understand about perinatal mental illness in this reproductive life stage. Now, what you will also hear is colloquially your patients and people that you may know, not in the medical community typically, or who are not familiar with perinatal mental illness much, will sometimes just call everything postpartum depression. Usually that's a postpartum experience, but sometimes they'll even term things like during pregnancy postpartum depression, or just postpartum. I hear a lot of my patients just say postpartum. I had postpartum, right? So just something for you all to be aware of. If you're hearing people talk, that's language that you might hear as well. Okay, so one of the fundamental things that you need to understand in order to just have a good sense of everything going on here is what is really driving these mental illnesses. Now, there's very good evidence that perinatal mental illnesses and other mental illnesses that occur in other hormone-mediated contexts, like around menstruation or in the perimenopausal period do have different presentations, typically different courses, different prognoses, things like that. So we know there's something different. Now, we don't give them necessarily different names. The book that we have, the diagnostic manual, we still call it depression. We still call it anxiety. We still name it by the names the diagnostic manual gives us. And we still use the same symptoms to identify these things. But we know that there can be differences in how those things show up. Okay. Even with the same symptoms, even with the same diagnoses, there are differences. What we don't fully know is exactly why. The best evidence that we have suggests that the insult is hormone change, okay? Not necessarily a hormone level, not necessarily sensitivity to a specific hormone itself, but hormone change. And the bigger the change, the more of the insult, essentially. When we're thinking about pregnancy, there's a lot of hormone changes, okay? The graph I have up here, if you know anything about pregnancy hormones, is a gross oversimplification of what is going on with pregnancy hormones. But I think it's a really good, just general reminder visually of what's happening with pregnancy hormones throughout the course of, or with hormones throughout the course of pregnancy. I do want to caveat, although the best evidence that we have is that change is the thing that really triggers mental health conditions when they're hormonally mediated. There is some evidence, especially from the research that we have on like PMDD, premenstrual dysphoric disorder, that some people are uniquely, and these would be certainly the exceptions to the rule, they are uniquely sensitive to maybe a certain type of hormone or to a certain hormone level. So that's the exception. That's not really what we're talking about, but it's important to kind of recognize if you're going to be in a position where you're managing folks, you might see situations where you're like, a hormone change doesn't seem to explain this, what's going on. There are individuals certainly who, for whatever reason, don't fit into this broader category. But for the most part, and what I want you all to take away today is it's hormone change. Okay. So that can help you to understand too, when are we supposed to be looking out for these things? So hormone change starts for pregnancy with basically at the moment of conception, right? From the time implantation occurs and up and through, even the first several days and weeks, there's a lot of hormone changes already happening. We know that for most women, their progesterone levels alone are doubling, tripling, quadrupling in that first several days and weeks. We have the start of hormones that are not usually in high quantities in our bodies, like HCG and things like that. There's a lot of hormone change that happens right away. And then towards the end of the first trimester, placenta takes over hormone regulation, or a lot of hormone regulation. And we know it does a lot too. Hormones that are not on this slide, for example, the placenta helps regulate melatonin and serotonin, helps regulate growth hormones, helps regulate other steroid hormones. There's so many things that are happening. So that's another time point when we see some vulnerability for somebody to experience new or worsening mental health problems. The second trimester for people who are doing well does seem to be relatively a stable time, probably because even though, as you can see, there are hormone changes happening in the second trimester, at the very minimum, hormones are steadily increasing in many regards. It's probably proportionally, the change is not that dramatic compared to the proportional change at other time points. So somebody doing well during the second trimester will probably continue to do well. Third trimester brings another point of vulnerability, probably because of hormone changes. Also, as like the body prepares to be closer to labor and delivery and things like that, but also like social and psychosocial issues like changes in sleep, increasing stress levels as baby's arrival comes closer, things like that too. Now, the single biggest insult, as you can see from this graph, is the hormone change that begins with labor and delivery. That there is no other hormone change that even compares across the reproductive lifespan. And this is by far the single biggest insult that we see to mental health in this perinatal period. People with low sensitivity to hormone change can very often still get mental health concerns because of this dramatic change in hormones, beginning with labor and delivery and through the postpartum period. Another thing not on this graph are hormone changes related to breastfeeding or nursing or lactation. So if somebody especially is going to wean very quickly, the earlier and quicker they wean, typically the more of an insult that seems to be, probably again because of the proportion of change for hormones. So that's a lot what we're looking at. If, for example, a person's normal, I don't know, can you see my cursor? Okay. If a person's normal hormone levels were up here, then going up a little bit up to here would probably not result in a whole lot of insult to their mental health, right? It's these big changes. It's the notable changes that we see that really are the insults that we find contribute to vulnerability. All right. Okay. So some key facts here. As Elizabeth kind of mentioned already, about 20% of women or birthing people will meet criteria for a mood or anxiety disorder during pregnancy or postpartum. This is the most common complication of pregnancy. That's kind of a catchphrase you'll hear used by a lot of advocacy groups, especially. And it is not an overstatement. I think some people hear that and they think like this is just a sales tactic, the most common complication of pregnancy. Really, it really, really is. I have had my head in literature on this topic for, again, the better part of the last decade. I have looked at many different angles of this. And if anything, probably that 20% is an underestimate. You will see variations in that number for sure. But that's a very, very good, solid round estimate to use when you're thinking about what proportion of your population will likely be affected. Now, if you're working in higher risk populations, for example, Medicaid populations or other underserved populations, we know that that risk is substantially higher, closer to probably 50% or more. Okay. So again, theoretically, this is the baseline risk, and then risk on top of that, probably with other population changes. If you're working in mental health or other fields where you're going to encounter people with more mental health problems, again, obviously that risk is higher. And it's just really important, I think, to take that away. Like, this is not a problem of, the few and far between. This is a problem of the many. And people are, there's a big gap, I think, in how many people are experiencing these concerns versus how many people are actually getting the help they need. Pregnancy is not a protected time. I say that, and I know I can't see all of you, but I know some of you are like, duh. And I'm glad that some of you are like, duh. But that honestly is an important thing to point out, because up until relatively recently, like within the last 2 decades or so, that was sort of the common medical perspective, was that pregnancy itself in particular was this protected period that reduced vulnerability to mental health conditions. And I still encounter people through no fault of their own who are operating under that assumption, right? And it's in large part, I think, related to our cultural perspective. Like, pregnancy is supposed to be this joyful, happy experience, right? Women are supposed to be joyful about being pregnant and about having a baby, right? And we just know that that is not only not the case, it also is the case that pregnancy and postpartum are a more vulnerable time. I will point out that not all of the mental health concerns that arise in the perinatal period have a higher incidence during pregnancy or postpartum, but some of them do. Some of them we can clearly see, like, the hormonal insults of this time period represent a unique impact to that illness. And so we see higher rates of either destabilization or rates of that illness itself, things like that. We've talked a lot about the biological component to these mental illnesses. We know that there's no mental illness that is completely biological, and there's no mental illness that's completely situational, pretty much, right? That's a pretty good general rule of thumb. But when we're thinking about these disorders, we do kind of put them more in like the biological category, just because of the context of the hormone shift and what we know that means for the brain chemically. And with that, or supporting that, I should say, what we've also seen very clearly in the literature is that these disorders respond better to medication treatment than these mood disorders and anxiety disorders that occur at other times. So we would say very clearly in this population, most patients do best when they have medication and therapy. Now, there are some patients, for sure, I have met these patients, I have recommended this myself, that have very mild illness that probably will do well with therapy alone. But for the most part, most of the patients we're going to encounter are going to need both in order to really do their best. The last key thing I want you to take away is that suicide during the perinatal, or suicide methods during the perinatal period, are different. They're more likely to be more lethal. Historically, and I'm going to use gender kind of binary terms in this case because that's kind of what the literature has looked at. Women have historically been shown to have suicide behavior that looks like more attempts, but using less lethal means. So, for example, overdose, which has more opportunity for rescue. Whereas men have been shown to have suicide behavior that is less often, but they will typically use more lethal means. There's a lot of variation. Like there's not one consensus about whether there's a change in suicide attempt frequency in the perinatal period, but we do for sure know that there is an increase in the likelihood that somebody will choose a more lethal mean, like firearms. So it's really important, because I think that's an area too where we're not necessarily, there's just a lot of discomfort in the spheres where birthing people are being assessed in or discomfort and just lack of information about how to do suicide screens, risk assessments. And so that's another area I think we could, be doing a bit more in. Okay, so what are the risk factors? Very importantly, some patients have zero risk factors, or no obvious risk factors, I should say, at least. It is not uncommon that we see people who have no history of mental illness. They have either no or very little history of mental illness in their families, and they still develop these perinatal mental health changes. There are absolutely people who are going to be more vulnerable, which we'll talk about, but I think it's really important to know that, like, there's not a population or a subset of this population that we should be screening and some that we shouldn't. Anybody who is going to experience pregnancy or postpartum is at risk of a perinatal mental illness, okay? The hormone change alone is enough of an insult. You don't have to have other risk factors to put you at risk for these types of things. Now, some people we know are more vulnerable. They have a history of mental illness themselves. Of course, they're going to be more likely to potentially experience an exacerbation or recurrence of that illness with a big hormone insult. People who have history of mental illness during pregnancy or in a previous pregnancy or postpartum, that's a huge key thing too. We think essentially from the literature, the best predictor of how somebody does postpartum is how they're doing during pregnancy. And most of what we would typically term postpartum depression, because that's when it's caught, like somebody will get diagnosed with it in the postpartum period, actually had symptom onset during pregnancy. So that's a huge, huge, huge risk factor. Recent stressful events. Yes, we've been talking a lot about the biological component of these illnesses, but there's a huge psychosocial component as well. And stressors and just the complexity of what life looks like when you suddenly, have a child and have a baby, add a child to the family, whatever you're doing, is extreme. Like there's just a lot of changes that happen with that. So stressful events absolutely can contribute. Problems with breastfeeding or lactation, probably for a number of reasons, probably because of hormone impacts, but also likely because of other things like the stress associated, and also impacts to sleep. A lot of people who are having lactation issues are doing a lot to help either increase milk supply or manage a baby that's having difficulty latching. And oftentimes what that leads to is less sleep. Poor social support, again, for many reasons, stress being a big one, and then also less sleep, probably with less social support as well. And finally, a traumatic birth experience. That's a huge risk factor. We know that not everybody who experiences trauma will develop a true psychiatric illness like PTSD. But a huge proportion of people who experience trauma will have at least what is termed a stress injury. If you have any interest in learning about that, my wonderful esteemed colleague, Dr. Westfall at UVA, has done tons and tons of work on that. Those are stress injuries are still things that often need treatment. So it's important to recognize that even if somebody doesn't develop full PTSD, a traumatic birth experience can absolutely lead to a condition that needs some attention. Okay. So we do not have time, unfortunately, again, to go into detail about the specific symptoms associated with each illness. But what I do want you to be aware of is that there's pretty clear evidence that across different diagnoses, and actually really across hormonally mediated mental health concerns in general, we do tend to see certain types of symptoms come more to the forefront, okay? Those types of symptoms tend to be anxiety, insomnia, irritability, and physical complaints. Those things show up just in higher proportion with more severity, more prominently in people who are experiencing hormone-related mental health concerns. And it's just important to keep in mind that, like, even though, yes, of course, if somebody's going to be diagnosed with a specific condition, they'll have to meet criteria for that condition, we might just not see it look quite the same. A really good example is perinatal depression, where very often the presenting feature, the thing that the person comes to seek care for, the thing that is sort of most obvious is anxiety. They're having what we would consider depression with anxious distress. And the anxious distress is so intense that that's kind of masking, until you dig a little deeper, some of the other stuff that might be going on with depression. Intrusive thoughts are a very common sort of presentation of anxiety. People who don't have OCD, which is typically associated with intrusive thoughts in the perinatal period, will still often develop intrusive thoughts. It's a very, very common symptom that we see for pregnant and postpartum moms, often involving thoughts of harm coming to baby. These are not the same as somebody wanting to hurt baby. In fact, very much the opposite. Intrusive thoughts are incredibly distressing, and people do a lot to avoid or minimize the risk of their thoughts coming true. Okay. Insomnia, very, very common association with perinatal mental health concerns. And we differentiate that from normal sleep changes postpartum in a few ways. Like, obviously, if you have a newborn, you're not sleeping the same, right? And normal sleep changes during pregnancy, like discomfort and things like that, causes sleep changes as well. Typically, some good rules of thumb are like, if the parent isn't sleeping when the baby's sleeping, or isn't able to sleep when the baby's sleeping, either because they are really energetic and don't need as much sleep, or because their thoughts are so anxious or racing, or they have a restless mind. Those things are all indications that's like insomnia, not just the normal changes that they're having. And then there's not much more to say about irritability. People just feel very irritable in this time frame. Anybody who has female reproductive hormones probably can imagine this just with general experiences with hormonal changes. Irritability is a very common thing that comes up when you're experiencing even really normal, mild reactions to hormonal changes. And it just tends to be more exacerbated when there's mental illness involved as well. And then physical complaints. These are those diffuse physical complaints. Like, we've done the workup medically, there's nothing that explains it, and still the physical complaints are happening. Particularly GI complaints are very common, but many others as well: pain syndromes, headaches, muscle aches, things like that. Okay, so what are the risks? The thing that is so important for me as a clinician and as somebody who I feel like I try to advocate a lot for this population, is that we shouldn't necessarily have to have other reasons to treat these moms, right? We shouldn't have to have that. However, it is extremely important, I think, when we are talking with stakeholders in different spheres, that we're able to point to these reasons when we're trying to make change, because these are often the reasons that people will start to like sit up and listen, kind of thing. We still have a culture, unfortunately, where, and I definitely think this is changing, which is very helpful and very positive, but I think still the culture overall is that moms should sort of be able to suffer through for the sake of their kids, right? Suffering of mom is enough. However, that is not even remotely or at all, not even remotely, the only risk factor or outcome associated with these untreated or undertreated mental illnesses. Okay. A couple of ways we can distinguish these: medical versus social. There's a ton of risks. This list is not comprehensive. And what we see is that when mental illness is not treated or not well treated during pregnancy or postpartum, there is a very, very high chance of a lot of different negative outcomes, both during pregnancy and after baby is born. We think on the medical side, this is related to the actual physical impact of just the stress that experiencing a mental health condition causes. We see that pretty clearly when we study long-term outcomes of things like depression and anxiety in general populations, that cortisol levels increase for those people, and basically the stress response system is just pretty out of whack when somebody experiences mental illness. And so those things, even in a person not pregnant or postpartum, lead to a lot of different like chronic illness risks and things like that. We think that's probably the same pathophysiology going on with a lot of these negative outcomes that we see on the medical side. There's also other factors too. Like, for example, somebody who is experiencing untreated or poorly treated mental illness is much less likely to get good prenatal care. They're much more likely to have to experience higher rates of substance use, and then direct consequences of probably those things and the cortisol soup, as we affectionately term it sometimes, are things like low birth weight and poor fetal growth, preterm delivery, other pregnancy complications, notably like preeclampsia and things like that. And depression during adolescence and offspring, and that is independent of the genetic risk of that person. And also developmental and behavioral problems, again, independent of the genetic risk of that person. Discontinuation of lactation, and then obviously very serious consequence, infanticide, homicide, or suicide. On the social side, people who have these untreated or poorly treated mental illnesses are more likely to be involved in child neglect and abuse. They are much more likely to have impaired bonding. And importantly, bonding, it's not so simple as just to say like the problem is just mom and baby aren't connecting. Again, another one of my colleagues, Emily Drake at UVA, did some wonderful foundational research that looked at really what bonding, what the impacts of bonding were, and found, she and now many other people since her, very clearly that impaired bonding leads to tons and tons and tons of consequences on its own. Some of the same that we see in other parts of this slide, but also additional consequences too. So it's a bigger problem than just mom not bonding well with baby. Relationship problems, employment problems, and then increased costs of healthcare are a big one. So again, you and I, people who work directly, especially with perinatal patients, we don't need to have a number necessarily of what this costs society. We know the costs are very high instinctively, but if you are in a position where you're going to be talking with folks about making changes, systemic changes to your system, this is a wonderful and excellent article that you can reference. It's from 2020. It's listed, the actual reference is listed for you here at the bottom. And it looked really thoroughly. It was a great, really well done article at what it costs the United States for basically each mother-child pair in a case where mental illness is untreated or undertreated. And the costs are really substantial. And you can see that the costs include a lot of different things, things that we talked about in the previous slide, but also additional things that they looked at as well. A lot of child-related costs that probably are of interest to a lot of the folks working in like pediatrics and neonatal care. And basically this is converted to $23 now. We're looking at close to $40,000 per mother-child pair. That's a huge amount of additional cost that is specifically and directly related to the untreated or undertreated PMAD, okay? That is independent of like other things that could contribute to this increased risk, okay? It's substantial. And I think a very good way to help certain stakeholders kind of understand this in different terms. So it's a great article. Please reference it if you'd like. It's a good thing to read through. All right, last thing I'll talk about is screening. So we talked about this screening treatment gap. Elizabeth talked about that originally. I do think that of all the things that we could be doing, which there are many, we could be increasing prevention efforts. We could be, I don't know, so many things, increasing access to insurance and reducing costs of care and all those things, right? Probably the simplest that we could be doing to really make an impact, where individuals, I think, have the most impact to be able to say, is to start or adapt their screening protocols in whatever facility or setting that they're working in is through like changes to screening practices. Way back when I started in this field, I shouldn't say way back, it's really not that long, but a good like 8 years ago now, the thing that we were really trying to accomplish was just increasing screening alone. There was just not enough screening happening. I still think that can be increased. Certainly there are places where screening is not happening where it could make a big difference, but we are seeing a lot more screening. What I want to connect today is how do we get screening coupled with treatment? How do we get patients from I screen positive to I can talk to somebody about that and get the right care I need? The recommendation, I'm going to make some recommendations. These are recommendations that you will find evidence for in the literature. They're also my personal recommendations as somebody who works in this field and who has an interest in seeing people get better care, right? Seeing this change. So the Edinburgh Postnatal Depression Scale is a wonderful tool. I think if you're going to use one tool and one tool only, this is the one to use. This is limited by your hospital systems. I have encountered hospital systems for whom they can only bill, for example, for a PHQ-9 and a GAD-7. Do what you need to do, but if you can choose, this would be the one that I would pick. It has been validated throughout the entire perinatal period. So from pregnancy day 1 through the first year of postpartum, across many cultures. It's available in many different languages. And we know that it's effective at identifying both depression and anxiety disorders. And there is some very good evidence that it can identify general disruption to mental health in the perinatal period that does not fall into one of those categories. So it's a great kind of like all-in-one sort of tool. It's also validated for dads if you're working in settings where that might work. I should say non-gestational parents as well. They have studied dads specifically. If you're working in settings where that is valuable. And my recommended cut score to you would be 10. So the original cut score for the EPDS was 13, and some people go as low as 9. What you get when you go higher on this cut score is more specificity. So more chance of correctly identifying somebody with a mental health problem, but you decrease your sensitivity. So you're not as likely to capture as many people. I think 10 is a good middle ground. There's some really good, easy to find literature on the different cut scores and their sensitivities and specificities that you can look up and make decisions about your facility or practice location. Really, really importantly though, whatever cut score you choose, scores between 7 and 10 have been pretty reliably associated with mild illness. And that can sometimes still require further treatment or assessment. So even scores below this mark might still need some attention. Now, what I want to do real quick before we end here is share something else with you, which is the resource packet that I have provided that you will hopefully be getting shortly, that I'm hoping will be a good guide. This is by no means intended to be like the solution for you or your facility or practice area, but I'm hoping that it can help start things off if you don't have a foundation for screening at this point. This is the EPDS. I have adapted this version. It is adapted by scoring. So all of the items in this version are reverse scored. In the original version, items 1, 2, and I think 5 are regular scored, whatever not reverse scored is. In reverse scored, all of the items, the first response is 3 points and the last response is 0 points, okay? And I did this because so many places like us in particular too, we don't have the capacity to auto score any of our screening scales. And I have seen many times EPDSs come through from other facilities where the scoring is off. And I think from what I can tell, it's usually related to these 3 items where the scoring is being conducted a little differently. People aren't aware of like the reverse scoring and things like that. So this could make it easier. Please know that this is the adapted reverse scored version. If you want to use the original, that's available too. And then I have some recommendations here heavily based on the literature about how to use this. This is also, these instructions are taken pretty much straight from the Edinburgh itself, but they're a little bit condensed for easier viewing. The biggest thing I can say is that when you're using the EPDS, always, always, always look at item 10 before that mother leaves your care, right? Before they leave the office, before they leave your facility, whatever it is, because this is the item that asks about suicidal ideation. Some recommendations here about how to use these scores, right? So not just screen, but what do we do with the score we get? How do we, again, connect screening with action? So here's the score. This gives you how you can interpret it and what the recommendation would potentially be. Again, you're going to have to potentially adapt that to whatever works for your facility. And again, item 10, how you can do that. Now, because a big problem I've seen is low comfort or just low like of information about how to do suicide risk assessment screens. I've included a lot of information in this packet about suicide risk assessment screening. I think one of the reasons that people don't screen is because they're fearful about what the outcomes are going to be. Like, what are they going to have to manage if they find it, right? Which is a very valid concern in healthcare. Things are quite litigious, right? We're supposed to be able to like do something about whatever we encounter. And I think this can give you a really good picture about like, how do you connect certain severities of suicidal ideation with some action? This is adapted directly from the safety card and safety protocols that are listed here. It just gives you this in like a little checklist kind of format with some suggestions. Like if somebody is low risk, what checklist things do I need to do to make sure that patient gets the right care. If somebody's moderate risk, what do I need to do? If somebody's high risk, what do I need to do? And then I've also included the Columbia Suicide Severity Scale. It's a pretty straightforward, simple way to just assess suicide severity. Okay. That's it for the presentation. We have some time for questions. And I would love to hear your questions if you have any. No pressure. Thanks, everyone.
Thank you so much, Dr. Reichenbacker. I love that. So thank you so much for coming on and sharing so much information. I can see your experience in the number of years you've been involved. Thank you, Elizabeth and Beverly, for joining us today. We really appreciate it. Please drop any questions that you have in the Q&A. Try not to drop them in the chat because it's easy to miss in there. So put them in the Q&A and I will try to share them as we go. The first question that's in here is, do you have a similar guide for PHQ-9 and GAD-7? Also, what are your recommendations for screening frequency for nurse home visitors?
Yeah, I do not have a similar guide for PHQ-9 or GAD-7, but I think you could use the suicide portion of that for any screening that's going to pick up on suicidal ideation. That would be reasonable. And screening frequency. So for nurse home visitors, those would be folks that are typically going in postpartum. I'm assuming that's the context that you're asking about for the nurse home visitor. In that case, I would say I would really love, this would be the ideal situation, if somebody could be screened at least by 2 weeks postpartum, and then again at 6 weeks postpartum, and probably then again at 3 months postpartum. Realistically, I think if we could get 2 weeks and 6 weeks, that would capture a lot of the vulnerability that we see from the hormone changes, and probably would suffice. But that would be excellent if we could do that. And then screening in general, like it's right now, what's happening so much better is screening postpartum, usually about the 6 week mark. I think if it were up to me and I could snap my fingers and have everybody do it the way I wanted to do it, we would screen like the first appointment that somebody has for their OB care, right? Like the first time we know they're pregnant. And then at every trimester also during pregnancy, because again, we know that those different trimesters represent different vulnerabilities for having these symptoms either worsen or onset. So, yeah.
The next question is, do you need to have a clinical background to administer these screenings?
That's a good question and will depend probably very heavily on whatever the regulations are in whatever setting you work in. I don't believe that there is like a legal requirement that I'm aware of, but there almost certainly will be some kind of facility specific procedures, guidelines, things like that.
Mm-hmm. This may be related. I know you touched on it a little bit, but this next question says, what are your thoughts about using the PHQ-2 and the GAD-2?
Any screening you want to do is great. Yeah, whatever your facility will allow, do it. Honestly, I think again, the EPDS probably offers a better picture of, or a better ability to capture more broadly what could be going on with mental health in the perinatal period. But I have talked with so many facilities where like they literally can't use it because they can't bill for it, right? And so what they end up using is PHQ-9, GAD-7, or some other screeners. So screening, if you can do the screening and couple that with helping people get to care, that's a huge thing. I actually didn't show you guys, but in that packet that you have, I did include actually like some resources for people you can contact to help your patients get to care. And a huge one of those resources is PSVA in our state, Postpartum Support Virginia. They actually have care coordinators. If you refer somebody into their care coordination, or you have the patient fill out that form that they have online, they will help that person get to care. They will find out what insurance they have. They will figure out if they need financial assistance, and they have programs for that, and they will help that person get to care. So that's a huge resource. That's number one on the list up there. And there's other resources in there for you to view too, that can be helpful. Yeah. Got off topic there for a second. Sorry. Realized I forgot that part.
Well, that's okay. The next question is, how often do you see postpartum depression in the non-gestational parent? So I'm assuming that means the partner or support person.
So statistically speaking, this has been pretty much only studied in dads, right? But we also know that there are non-gestational mothers and people who don't identify as either. They identify as non-binary. But statistically speaking, in dads, that's about 10%. And I would say that seems to add up. I don't see it a lot in my practice because dads are not necessarily the folks that we're seeing much, just based on like what we're doing medication wise and specialty wise. But we definitely do see it. We just one of our clinicians just had a dad recently who came to care. I think there's still a lot less treatment seeking behavior in gestational partners, or non-gestational parents, I should say. So there's that aspect as well, but statistically speaking, probably about 10%.
The last question I have, so if you have any others, feel free to submit them. But it says, do you recommend screening during the hospital stay with the Edinburgh?
Absolutely. I think that would be excellent because again, we know that so many people, this is not statistics that I could share today just based on time, but really like statistically speaking, most of what we would identify and call postpartum mental health problems have already started by the time during pregnancy. And so we have the opportunity, anytime we can capture that earlier and get a person to care earlier is better. So screening in the hospital is absolutely worthwhile. There are also some really severe mental illnesses that will start to present themselves with labor and delivery that sometimes can be captured in the hospital setting as well.
One second. And so this question says, as nurse home visitors, we notice so many moms who screen positive, but for various reasons and don't want to seek care, which can be very concerning. What would be the recommendation for supporting these mothers while staying within our scope as nurses?
That's a really good question. I mean, we have this all the time. There's a lot of still, like that was one of the barriers Elizabeth talked about, was like the stigma and fear people have. Fear is a big part. I hear a lot of moms who are still really worried about what is this going to mean for them and their babies if they tell somebody I'm struggling, right? Or if they really get formal care. They might trust their home visiting nurse because they have a really good relationship with that person to say I don't feel right, but they might not trust anybody else, right? And I would say anything that is supportive of that person moving in the direction of getting help is the right move. You can take a harm reduction approach, right? The person's not seeking care, even though you're recommending it, that's fine. You can still reduce the risk of harm by offering supports where possible, right? What can you work on with mom are there like fears that she has that really aren't going to be borne out in what she's going to experience that you can talk with her about? Are there other reasons she's fearful or doesn't want to seek care? Like, what is her perspective on that? Is there anything that can be done to change her mind? And if not, what does she need to just like get by day to day so that she can continue to function in the way she needs to? And how can you help and support that? So there are people that aren't going to want to seek care, and that's okay. Like that's their right too. So yeah, harm reduction approach is what I'd say.
And then I have a question. If anyone else has one, we have just a couple more minutes. What would be your ideal situation for communication between clinical services and folks that have your type of specialty? Because I think people often, or especially clinicians, sometimes often say that they don't have a lot of time to keep all these resources in their head. Or if they have someone screen that may need a higher level of care, what would be your ideal situation of how folks like you and clinicians working every day could best communicate and reach each other?
Well, if I could snap my fingers, there would be a mental health person in every setting that's going to encounter mental health, which is every setting of medicine that I'm aware of. That doesn't happen in reality. And so I would say the answer at that point is probably like relying on the resources we do have, like PSVA, that can offer that bridge. Honestly, that's the best solution we have so far is PSVA's resources. The fact that they have care coordination services at all is kind of a miracle and a wonderful thing, and to use those things. That secondarily, if there are other resources that you can tap into within your system, like if you're working in a big hospital facility, are there like mental health resources available, just maybe not perinatal? That's at least something, right? It's not necessarily ideal. We know that there's a lot of psychiatric providers who have really poor information on this topic, but it certainly can be a step in the right direction. Therapists or social workers that might be able to handle some of like the complexities of getting somebody like from the point of screening to getting an appointment somewhere, or even just like giving them a packet of resources, things like that. Yeah.
Absolutely. Thank you so much. Again, we really appreciate you all joining today, joining the webinar. And I think everyone that attended got a lot out of it. Thank you for the resources. We're definitely going to be sharing them after the webinar as well. And as a reminder for anyone who came in late or wanted to share this with a colleague, we're going to be posting the recording to our YouTube page. And then you can also join the VNPC newsletter to stay up to date on other announcements and the rest of our webinar series, including our LGBTQI+ series that will be starting this month as well. So check that out on our website, govnpc.org. You can find everything there, or you can feel free to email any of us. Thank you again, and we'll get ready to close out this webinar. We look forward to seeing you at the next one. So thank you.